morning, ma'am. Thank you for the kind words. And thank you, Dr. Moses. And first, I must thank Dr. GVK for inviting me for this important session and also giving me the topic that's closest to my heart, which is follow-up of women with GDM, because I really think this is where we drop the ball, because everyone is happy once the baby is born. The mother is happy, the OB/GYN is happy, the diabetologist is happy, and then the woman is forgotten. But we know what happens to the forgotten woman. The IDF Atlas has, the most recent one, has told us that about nearly 25% of the pregnant women in Asia have some form of hyperglycemia. But just to put this in perspective, India had 30 million births last year. That's more than the population of Nepal or Sri Lanka or even Australia. And so even if 10% of women have GDM on an average across the country, put everything together, that's 3 million women, not 3 million babies, but 3 million women who have had GDM. And even if 50% of them go on to develop type 2 diabetes in the next 5 to 10 years, that's 1.5 million women every year that's being added to the pool. And as is, we have close to about 205 million women with diabetes across the country, and about 35 million in our own country. And across the globe, and 35 million in our own country. And we know that GDM increases the risk of type 2 diabetes. So in a follow-up testing in the WINGS database, you could see that as much as 20% of women had some form of dysglycemia within the first year, which is very, very significant. Can we make this into a slight transition? This one? Just make it into a, yeah. Okay, so just do this one? Okay, great. So 20% of women have some form of dysglycemia within 1 year. Forget about the 50 to 70% who may go on to developing type 2 diabetes. So we know for a fact that women who have had GDM are at very high risk for future type 2 diabetes. And there is a battle cry of sorts asking physicians, us diabetologists, the OB/GYNs, and the women in the community themselves to come back for follow-up after GDM and to stay in a program so that we can prevent GDM in future pregnancies and we can hope to prevent type 2 diabetes. So the risk of future GDM in the next pregnancy is very, very high, as you can see. And therefore, even if you take the woman who has had GDM in this index pregnancy, and we are able to follow up this lady, we can try and prevent GDM in the next pregnancy. And we know that GDM increases the risk of diabetes in the offspring and increases the risk of type 2 obesity and abdominal obesity in the offspring. So if we are able to prevent GDM at least in the next pregnancy, you can see a whole cohort of children whom we can prevent type 2 diabetes. One of the things that beginning to concern all of us is GDM by itself is increasing the risk of cardiovascular disease in women with GDM, so how important it is to keep them in our follow-up, and cardiometabolic implications of postpartum weight changes in the first year after delivery has been looked at, and adverse cardiometabolic profile emerges as early as 1 year postpartum in women who did not lose weight between 3 and 12 months after delivery. And here I want to tell you there is something very unusual about women in our country who seem to gain weight after delivery than during pregnancy. So much so that one of the Tamil magazines, Aval Vigadan, had a cover story that said, "Nam Natil, Kurandai Pirappukku Pin, Amma, Gundamma Avadi Ain." And the cover had Aishwarya Rai. We all know that she gained some weight, but the message that I want to give is it's really, really important to empower women with the knowledge that they need about the future risk of cardiometabolic profile, future risk of diabetes, and future risk of heart disease. Moving on to this really important thing, one of the other reasons why we need to keep our women in the follow-up is because when they have another episode of GDM, also want to tell you, if they have a girl child, this child is at risk not just of type 2 diabetes, but also at risk of gestational diabetes, and this cycle is going to keep going on. So the transgenerational impact and the intergenerational programming that is going on with GDM is something really, really important and important to keep in mind. When women develop diabetes, it's not the same as men. I know that I will be looked at as some card-carrying, flag-waving feminist speaking only about women and diabetes, but it is true. Diabetes in women is different, more difficult, more deadly, and dismissed. So we really need to keep in mind more heart disease, more strokes, more depression, more fractures, less cared for, less attention, so many things. And of course, the responsibilities of caregiving and poverty and other drivers of and innate health and inequities for women and gender disparities adds to these complications of diabetes in women. So how do we follow up our women? So before hospital discharge, make sure that we discuss the risk for diabetes. The tone that we set as soon as GDM is diagnosed is really important, and throughout their pregnancy, the tone we set. Very easy to say, you have some pregnancy-related diabetes, don't worry, it'll go away. Konja careful arungo, konja paathu, be careful. That is, we are doing them a huge disservice. We really need to tell them, this is a wake-up call. You are at very high risk for future diabetes, and impress upon them that they cannot leave our follow-up. So, discuss risk for diabetes, encourage breastfeeding, because breastfeeding prevents type 2 diabetes in women with GDM. So 6 months of exclusive breastfeeding and at least 1 year of complementary breastfeeding is really important for women with GDM. And we must schedule the postpartum follow-up. The postpartum follow-up, they come back for pap smear, they come back for a million other things, but don't come back for this. We don't know what it is. I'll show you some barriers. So if they are, and we have to do a 75-gram GTT at that particular time. We also have to discuss family planning and make arrangements for that. If they are found to have diabetes, lifestyle and medications that is appropriate for a breastfeeding woman. If it is impaired, of course, again, lifestyle modification and keeping her in follow-up and testing more frequently. And of course, if she's normal, she's still at very high risk for future type 2 diabetes, so lifestyle modification and follow-up. Even though the ADA talks about 3 yearly follow-up, I think for our population, we should be having yearly follow-up. So when this question, again, as part of WINGS was shown, do you advise postpartum GTT for all women with GDM? And if so, when? Just to show you that there is a huge disparity, but whether it's diabetologists or OBGYNs, we're not doing such a great job. I think the numbers should come to 100% on both sides. So even the global practice patterns are not actually that great in terms of follow-up of women with GDM, so we should try really to do better. And what can the barriers be? Why don't people come back for follow-up? It could be societal, newborn baby, don't go there, kannu patron, all those things. Or financial reasons, be able to go there, and then knowledge and awareness. Sometimes it's just fear of finding out something that they don't want to find out, or they may be in denial. Where will they breastfeed? They have to keep a newborn baby for 2 hours somewhere. So we have to think of all those things and help them with that. So the healthcare system needs to be strengthened. And then, like I said, the logistics, whether it's breastfeeding or getting there or how to get this done. So we need to work on how to help this lady on getting the test done. And what are the benefits of postpartum follow-up? Early detection of diabetes and pre-diabetes, enforcing lifestyle changes, recognition of CV risk factors, early intervention if they have a problem, planned pregnancy for the next one, and prevention of future GDM and diabetes, and preventing and delaying complications of diabetes. So I mentioned about postpartum weight gain, and this is something that is really beneficial when we have a postpartum follow-up. The gestational weight gain, which leads to problems. If during the second pregnancy, in between, we have not followed them and counseled on weight management, this is what is going to happen, and later in life, increased risk of type 2 diabetes and cardiovascular disease. And in a very interesting study, the radial study, the Finnish GDM study, actually showed in women with GDM, a moderate individualized lifestyle intervention reduced the incidence of GDM by 39% in high-risk pregnant women. So there is proof that if we intervened, at least the next GDM can be decreased. So what should a clinician do? Recognize the scope and significance of future risk of diabetes, promote universal testing, which, very, very important. Key reinforcing the mothers about their future risk for diabetes. Encourage breastfeeding, so important. Discuss planned pregnancy, preconception care, and keep reminding the patient that to have regular follow-up after her GDM pregnancy. Keep an eye on the babies of the mothers with GDM and partner with the pediatrician. And during every visit that the patient comes to the OB or the diabetologist, we should talk about future risk, because it's actually our own myopia. We tend to think the doctor says, I know she could develop diabetes, but now let me tell her she's okay. I don't want to frighten her. The patient knows that I know I may develop diabetes, but right now let me worry about the baby and let me not think about the future. So there is a big myopia. So this is the lactation data, and we should aim for universal coverage postpartum. Universal coverage as in universal screening of women postpartum. Really, really important. Follow-up of women with GDM is a challenge, but one that absolutely cannot be missed, as it provides a great, great, great opportunity for prevention. We always think that every mother deserves a baby. Every baby deserves a healthy mother for the long term. Thank you so much.